Ciao mondo, hello world, hola mundo, hello mon, and konnichiwa for our Japanese friends. We're here today in Brussels with Professor Jean-Louis Vincent and the 2016 edition of the ISICEM meeting. So Jean-Louis, what is new and what are the highlights this year of this meeting?
So many things, my good friend. It's difficult to list them all. But you know, Professor Ronco came in with the results of his new study, Do, Re, Mi, Fa, on fluid administration and the influence on the development of renal failure. There is a lot on fluid administration, how much fluid, when to stop, when not to give too much fluids, because we know that fluid overload is really associated with worse outcomes, and that's what Professor Ronco's study also showed very clearly. We also learned that we need to go for more precision medicine. We should stop studies on large number of patients with heterogeneous diseases, just counting the number of dead people and surviving people. We need to be more specific and study patient populations which are much better defined. You don't think so?
No, absolutely. And in fact, this personalization of studies and identification, characterization of patients will allow us to avoid, to eliminate potential therapies that in the past apparently failed, but they may be beneficial for some group of patients, right?
Exactly right.
And,
absolutely.
I think that the problem will be to see how to balance this more and more personalized medicine with the so-called pragmatic trials on large databases. But there was a paper presented on how to match.
Yeah, it depends on what you want to study, because of course if you want to study blood sugar control in the ICU, you have to go for a large patient population, obviously.
Right.
But if you would like to study, you know, the effect of one intravenous fluid versus another, you know, as I always say, saline versus balanced crystalloids, why don't you just look at chloride levels? And when the chloride levels increase with saline, you stop giving it. Right. But people don't seem to look at chloride levels, and they want a prospective randomized control trial on saline versus balanced crystalloids. It doesn't make sense.
Okay, so for our young fellows, our young followers, what would be the message that just if you have to deliver one message to them for a good clinical practice today, what would be the message?
We still need a good doctor at the bedside, examining the patient carefully. But biomarkers will help us much more in the future, because we cannot see everything when we examine the patient. But biomarkers for sepsis, for acute renal dysfunction, for other things, will be increasingly important to guide our therapies in the future.
No, I agree. And so do not use alert system or electronic medical record to replace the visit at the bedside. You still need to be there. We need good doctors at the bedside, and all the digital and new methods, including electronic medical records, are additional tools to practice good medicine. Do you agree with that?
I agree.
And with this, thank you very much for joining today's Cappuccino in Brussels, and have a wonderful day.
Excellent.